I will introduce some of our friends. Of course, this is Jackie. Jackie, thanks for being our DJ.
Absolutely. So I'm Jackie Hale-Wersinski. I work at Vios since October of 2019. I am the recruiter and the talent development specialist, and I'm here to facilitate and help have this awesome discussion today. I think one of my favorite things to talk about at Vios when I'm speaking to potential new hires and our candidates is the really amazing things that Vios is doing for their patients and how we are making a difference in talking to patients and hearing their stories and listening to them. And I know a lot of people who come to potentially work at Vios are excited to share that journey because they themselves also, empathize because they've had either that difficult journey or have, really wanted to participate in helping other women and other families grow their families. So I'm really grateful to be here today. I would like to introduce everybody to our, to our amazing panel today. So we have, first of all, Dr. Angie Beltsos from Chicago Clinics, who is our CEO, founder, and Chief Medical Officer, Medical Director. We have Dr. Amber Cooper, who is our St. Louis Regional Medical Director. And we also have Dr. Violet Klenov, who is one of our amazing providers in the St. Louis region as well. So with that, I would love to get us started. Again, everyone, attendees, you are welcome to ask questions at any time. If you'd like to type that into the Q&A chat box or into the chat box itself, I am happy to start answering questions at the end of our session. If you have a question immediately, please raise your hand, and I'm happy to also call on you at the end of our session. Okay? All right. Violet, would you mind starting us off?
I would love to. So here at Vios, we've developed a Center for Excellence, specifically in PCOS. And our mission statement is to help women who have PCOS to optimize their health, hormone balance, and fertility success to achieve happiness as they lead their lives today and in the future. Because as most of our referring providers know, PCOS affects multiple aspects of life, not just the fertility world. And so we strive to care for those women throughout their lives after we hopefully help them to build a family. We can go to the next slide.
Oh, there we go. Okay.
Thank you. So PCOS is an extremely prevalent disorder. So approximately, 2 to 8% of all women are diagnosed with PCOS, potentially even more. There is a genetic predisposition to the condition that we don't have the specific kind of details in regards to which genes is it. Likely it's a multifactorial disorder. But we definitely know that it's hereditary, runs in families, that we're much more likely to have PCOS if the mother or sister is also diagnosed. And generally affecting ethnicities not equally. So Caucasians about 5% risk, African American population about 8%, and then Hispanic or Latino population about 13% are diagnosed with PCOS. So pathophysiology of PCOS, and boy, there's chapters and chapters on this. So the summary kind of take home is that we don't know everything still quite about what causes certain women to be predisposed to PCOS. Is it a multi-hit kind of hypothesis? Is there a genetic factor that is then activated by a lifestyle factor such as obesity? There's a lot of interesting theory, but generally we believe that women are prone to hyperandrogenism due to abnormalities within the ovarian steroid synthesizing pathway that then predisposes women to hyperinsulinemia, metabolic dysfunction that affects multiple aspects of health, and then prevents regular ovulation and kind of consistent maturation of oocytes. This kind of feature of hyperandrogenism feeds back to hyperinsulinemia, which then feeds back to hyperandrogenism. So it's kind of fuel on fire. So these patients will come in with concerns for hirsutism, and then they will be found to have insulin or glucose intolerance, and then that glucose intolerance makes hirsutism worse. So it's an important cycle to break, and all of those factors at the molecular level kind of predisposed to elevated LH levels. Is that potentially causative? But then certainly leads to a breakdown in the oocyte maturation process and inability to ovulate regularly, and then elevated levels of resting estradiol, which then puts these patients at increased risk for things like endometrial hyperplasia. So how are we diagnosing PCOS? So there's lots of different kind of institutions that have put out recommendations. I'll say generally we are for the most part following Rotterdam diagnostic criteria for the diagnosis of PCOS, which requires 2 out of the 3 criteria to be met, presented here in this middle column. So ovulatory dysfunction, androgen excess, and we'll talk a little bit more about kind of the specifics for this diagnosis, and then polycystic ovarian morphology, which has also kind of evolved over time. And then we have to exclude other conditions, which we'll discuss in detail in the following slides as well, before we can definitively state that this patient has PCOS. So irregular menstrual cycles, generally, oligomenorrhea, we think of less than 8 cycles per year, or a long intermenstrual period of greater than 45 days. It is important to consider that ovulatory dysfunction can occur even when patients are having quote unquote regular cycles. So it might be that they're ovulating irregularly or not optimally. And definitely check in a cycle day 21. Progesterone can be helpful to confirm your suspicion for whether or not you think they're ovulatory. I'm generally thinking of a progesterone of greater than 3 as suggesting that that patient ovulated. And then, of course, when to start the evaluation. If you see a patient who's trying to conceive and we feel like they are not ovulating regularly, has issues with amenorrhea, oligomenorrhea, definitely don't wait to start that evaluation until they've been trying for 12 months. Like to start that evaluation on the earlier side to help them achieve their goals more quickly if they're not ovulating. Hyperandrogenism. So this can be, the patient stating that they have issues with, I kind of phrase it usually like, do you have heavier than you think is normal hair growth? It's always a little bit relative if they, these things run in their families. So it can be just a clinical diagnosis based on what they're telling you and based on your exam, using the Fairman-Galway score. The Ludwig visual score is a score of alopecia due to higher testosterone levels. If you're checking biochemical evidence of hyperandrogenism, our go-to usually is a total testosterone. Doing things like a free testosterone and equilibrium dialysis assays, I would generally, the recommended test to start with would be a total testosterone. Checking things like androstenedione and DHEAS can also be helpful to help determine source for hyperandrogenism if you're evaluating other things. And then typically wanting to not test when they are on an oral contraceptive pill, as that can alter your testosterone values. So as far as ultrasound criteria, so we want to take a look at ovaries transvaginally, ideally at the beginning of a cycle, if they are occasionally ovulatory, because what we're looking for is those antral follicles, or those follicles that are about 5 to 10 millimeters in size, and then you count on each ovary how many of those antrals are present. The Rotterdam criteria was a total of 12 antral follicles on one ovary, or a volume of greater than 10 milliliters. More recently, we're using diagnosis of really more than 20 follicles on one ovary to help us make the diagnosis of polycystic ovarian morphology, as we were probably over-diagnosing this polycystic ovarian morphology, especially in younger healthy women who just have a healthy ovarian reserve. We can go on to the next slide. And as far as taking a look for PCOS in our adolescent population, we're generally not wanting to kind of over-diagnose when polycystic ovarian morphology can just be a normal healthy finding in an adolescent or young adult. You can get a sense for, is this patient going to be at risk for ovulatory dysfunction without giving a formal diagnosis of PCOS. Again, PCOS is a diagnosis of exclusion. So typically I'm ruling out things like thyroid disease, hyperprolactinemia, non-classic congenital adrenal hyperplasia. And then additional tests as indicated to look for like hypo causes for amenorrhea, things like Cushing's disease, cortisol excess, or androgen producing tumors. So what do I need to be checking? You know, what am I looking for when I'm seeing a patient that was sent to me, or things that I'll be evaluating when they hit the door? Is going to be a TSH to look at their thyroid, prolactin, 17-hydroxyprogesterone to rule out the non-classic congenital adrenal hyperplasia, a total testosterone, DHEAS, really to be looking at any adrenal source of hyperandrogenism, a fasting lipid panel if I'm concerned for PCOS because they're at risk for hyperlipidemia. Usually also checking markers of ovarian reserve, including some gonadotropins, so the LH and the FSH, and kind of looking at the ratio between those two. That's less of a kind of robust diagnostic marker, but can point you in the right direction if the LH is higher than the FSH. And then screening to look for glucose intolerance. So doing a 2-hour oral glucose challenge test. I will say in clinical practice, a lot of times I'm getting a hemoglobin A1C because it's hard to get a patient to come in fasting, and if they're there and you're drawing blood, we do often draw hemoglobin A1C, but the most accurate kind of test to help diagnose is going to be the 2-hour oral glucose challenge test in these patients. Associated conditions that will have impacts for the rest of these patients' lives. So they're at risk for high blood pressure, high cholesterol, diabetes, obesity, obstructive sleep apnea, with some really interesting data suggesting that they're at a much higher risk than the baseline population. Hyperplasia, depression, anxiety, and eating disorders. And over on the right is kind of how we typically will screen for these associated conditions and assess risk. All right, and just a quick review, it's been a while since I'm, diagnosing diabetes. I'm certainly not treating it on a regular basis, but we certainly do treat glucose intolerance. And there's some data about metformin, which we'll get to later on in the slides. But if we're checking a random fasting glucose, we like to see that as less than 100. And impaired glucose is going to be 100 to 125, and then frank diabetes is greater than 25 and needs to be confirmed at least twice. 2-hour glucose tolerance test, the result for normal is going to be less than 140. Pre-diabetic is going to be 140 to 199. And then frank diabetes on this test gives you a result of greater than 200 nanograms per deciliter. Patients with PCOS are at higher risk for metabolic syndrome, and we need 3 of those 5 characteristics to qualify for that. So waist circumference, triglyceridemia, an HDL that's less than 50, elevated blood pressure, and then an elevated glucose. Kind of working in conjunction with primary care providers to help manage those patients and their comorbidities is critical.
Okay. Thank you so much, Dr. Klenov. Dr. Cooper, I would love if you could go over treatment options with us.
I would love to. All right, next slide. All right, so there's sort of, 2 fields of thoughts and treatment options, obviously for women who do not desire pregnancy at the current time and those that do desire pregnancy. For women that don't desire pregnancy, at least in the short-term period, there are some treatments that probably many are you familiar with that do work to lower androgen levels or improve insulin sensitivity. And we can talk about some of those things. Well, metformin will come back in a little bit later and go into detail. Oral contraceptive pills are a very common first-line therapy. The synthetic estrogen or ethinylestradiol will make the liver increase sex hormone binding globulins. So that in turn will bind up some of the testosterone, which is probably the most beneficial sort of piece of oral contraceptive pills that help. There's always debate, and a lot of OBGYNs will ask about which pills do you like, or which generation of progestins or synthetic progesterones in the pill are better, are some more pro-androgenic or anti-androgenic. To be honest, the ethinylestradiol making sex hormone binding globulins and binding the testosterone is the most powerful part of pills. So even if they're a little more pro or less androgenic, it's probably still overall beneficial, especially if trying to slow hirsutism or improve some of those testosterone levels. I do think some of the anti-androgens are a little more helpful if you are choosing pills. Mirena or levonorgestrel, IUD, can be very helpful. If they are not cycling, cyclic Provera, if they do not want an IUD or an oral contraceptive pill. Weight loss, I mean, we're going to go into that in the next slides. Diet and exercise are critical. We're going to dive a little further in there, and it is always where I start conversations with patients, no matter what, whether they desire pregnancy or not, and then really treating their comorbidities, including any insulin resistance or diabetes. Next slide. So for those desiring pregnancies, there's a lot of approaches. You know, we're sort of summarizing here both ASRM and ESHRE, which is the European version of ASRM, recommendations. And again, always start with lifestyle modifications. And vitamins, Myo-inositol, so each of these things are going to be touched on in upcoming slides. Insulin resistance, so your insulin sensitizing agents like Metformin. Ovulation induction, so obviously women, like Violet just talked about, that with PCOS often do not ovulate or do not ovulate well. Some women will have regular cycles and believe they ovulate, but they're not ovulating well. So we do use ovulation induction agents. Over the years, letrozole has become much more popular, if you will, than clomiphene citrate or Clomid, especially in patients who are overweight or obese. The data is more powerful with letrozole in patients who are overweight or obese, and it is not FDA approved for ovulation induction, but the safety data of letrozole has definitely improved over the years. For those who have very resistant PCOS, they often do require either a combination of oral agents and gonadotropins or injectable gonadotropins straight, which become risky for hyperresponse, and these patients sometimes will choose IVF just due to the risk of hyperresponse. Ovarian surgery, like laparoscopic drilling, Dr. Beltsos will go into in her slides, and then eventually IVF as a treatment. Next slide. So lifestyle modifications, weight loss, weight loss, weight loss, weight loss. So, I always say in my line to patients is don't use the word diet. I don't like the word diet. Let's look at healthy lifestyle changes. I really basically try to teach them about clean eating, less preservatives, less artificial sweeteners. Artificial sweeteners are more pro-inflammatory. I really try to teach them about the glycemic index of foods. If there's one thing I say, go to Barnes & Noble or buy, get on a Kindle or buy a book online about the glycemic index of foods. The higher the glycemic index, the more foods turn to sugar. And really, if they can learn about the types of foods they eat, certain fruits have high glycemic index, some have low glycemic index. Patients with PCOS are very sensitive to changes in sugar. If you teach them just some small things, they will lose a little bit of weight. And even a 5% decrease in weight can make a big difference in their insulin resistance, their ovarian responsiveness, and their ability to get pregnant. Just get them walking. Half the time, most patients have, Apple Watches or Fitbits, or they have the ability to watch their steps, talk them into taking the stairs instead of the elevator, going for walks at night, really starting to move up into a little more cardiovascular exercise. And I teach them just little weights, basic strengthening exercises. If you build muscle mass, you ultimately will burn more calories over time. So these are very easy, quick things to teach patients about lifestyle changes. Next slide, bariatric surgery, yes. Yes, just to touch on that, for extreme obesity, sometimes that is the way to go. I do sometimes refer those patients to bariatric surgeons, especially if they have comorbidities. If they are young, they have a good egg pool, and it could benefit their health long term. A lot of bariatric surgeons want to see them wait at least a year for maximum weight loss, and it just depends on those who you refer to. But sometimes in the young patients with extreme obesity, good egg pools that have a little more time to wait, that may be the way to go. There are a lot of books out there. The Fertility Diet by Jorge Chavarra, who's at Harvard, is one I really, really like, and I have told patients about. Overall, patients who really want to learn about diet and fertility. There's cookbooks like this picture for PCOS. I tell patients to buy a book on the glycemic index of foods. just those basic things. Then I next teach patients about clean eating. I always say less out of a can, less out of a box. The more you can do that, the better. Preservatives, plastics, and artificial sweeteners are probably the three biggest things that lead to more inflammation, which in turn worsens metabolism and worsens PCOS. Some will say more plant-based diet, and you will hear that quite a bit. So it's not that, keto diet, you're going to get asked about that. Some of those fats and animal fats particularly are really, they raise cholesterol, they cause more inflammation. While it may jumpstart weight loss, it's not the best thing to do. They get more acidotic long-term. Good fats, omega-3s, fish, so your salmon, cod oil, anchovies, sardines, so some of your high omega-3 fats. Nuts, avocado, things with omega-3s are also anti-inflammatory. Fiber and water and multivitamins are very, very helpful. And again, exercise, like we talked about. Myo-inositol is a hot topic. I get asked about it by a lot of patients. Myo-inositol is sort of in this family of B vitamins. And an easy way to think about it is this. Our bodies do produce myo-inositol naturally. And myo-inositol, while it's fine in supplements, and I encourage it, I always encourage getting supplements out of foods, getting what we need out of foods if you can first, and then using supplements. So, what foods are rich in myo-inositol? Some fruits. Cantaloupe is a big one, and oranges are a big one. What else? Nuts, grains, beans, some of those things have myo-inositol. Myo-inositol, while it should be made naturally by the body, only a small amount should normally be converted to D-chiroinositol, which is bad. So you kind of think of myo-inositol as good and D-chiroinositol as bad. In that conversion, if there's too much conversion, myo-inositol is depleted, and this is bad for cells, including the follicles in the ovaries. So if you can replete that myo-inositol back up, and there's some data it might also work as an antioxidant, but it might help structure of the cells. It may help lower androgens. It may help improve the cytoskeleton of the egg itself. There's a lot of fascinating data out there. It's still sort of accumulating. Problem with many supplements is you'll find hundreds of manufacturers, and supplements are not well regulated by the FDA. So it is tricky. Patients ask, well, which one do you recommend? Which one's better than the other? It's really hard to answer that. We've put on these slides a couple publications that I think are worth looking at if you really want to see some of these randomized trials to see data and benefit. But most of these trials, when you look at myo-inositol, it shows that it improves how the cells respond to insulin, and it really lowers androgens. And in some IVF data, we see improved egg quality and potentially embryo development. Next slide. This is just one of those studies there where after 12 weeks, we saw sort of improvements in testosterone levels, insulin levels, LH and FSH ratio, insulin sensitivity overall. In patients who were tracking cycles, their cycles became more regular. And when it was compared to folic acid alone, there was no difference in the folic acid arm. Next slide. What about insulin sensitizing agents? Metformin is probably the one we talk about the most. Metformin improves how cells use insulin. So in turn, you're improving their insulin resistance. There is some emerging data that metformin also has anti-inflammatory properties. And that's really important when it comes to women and obesity and wanting to be pregnant, because the immune system and inflammation is really important for implantation and miscarriage. Where, we used to, years ago, 10, 15 years ago, we used to stop metformin as soon as a woman was pregnant. Well, safety data has been accumulating, and we do use metformin a little bit longer because there is some data it might decrease miscarriage rates. There's some concern from some manufacturers out there. We have to watch this data very carefully. There are some OBs that continue metformin throughout pregnancy to lower risk of gestational diabetes. All this safety data has been accumulating over the years. I still think we have to keep an eye on it, but it is definitely the benefits far outweigh the risks. Next slide. So basically, this are just kind of current recommendations. I think that's one of our awesome embryologists, Kat, that was live on Facebook. So, so the use of metformin also should be restricted to patients with glucose intolerance, and decisions should be left to obstetricians providing care. So again, it's just really a statement to say we have to still watch, and like anything else, data accumulates over time. We have to watch safety data continuously. Next slide. This is, sort of the classic reproductive medicine network study where we ask the question, clomiphene, metformin, or both for PCOS. This is really what kind of started moving our thinking along. Next slide. So this was a study done by the NIH where it was through the Reproductive Medicine Network. And really what they did was they were looking at either metformin, Clomid, or a combination of the two. Progesterone levels were measured weekly, and they looked at live birth rate in these arms. And really, what they were looking at in this study, so it was a double-blind, placebo-controlled study that was up to 6 weeks, 6 cycles or 30 weeks, if I remember correctly. They went all the way up to 1,000 milligrams twice daily. This is where a lot of this data says probably patients with PCOS need at least 1,500 milligrams a day, if not up to 2,000 milligrams a day if they can tolerate it. Progesterone over 5 was considered ovulatory, and they did timed intercourse cycles, no trigger shots or inseminations, and meds were stopped with pregnancy. So if you look at the success rate here, you see the success rate of metformin, clomiphene, and the combination. So sometimes that combination can really help kind of push us just over the hump. The bottom line is they do usually need some ovulation induction medication, and a combination in many patients, particularly probably patients that have obesity, may be very helpful. Next slide. And my last comment, I would just say there has been some recent warnings on the extended release metformin by some manufacturers. If you haven't seen those, I just encourage you to look at those. You may want to consider either immediate release in the short term, or really look at those manufacturers or the lots that they've put out. So with that, I'm going to hand it off to Dr. Beltsos.
Hi, everyone. I know we have a few more minutes and we wanted to give people a chance to talk, so we'll go through the rest of the slides. The question of using ovulation medication, letrozole, as you know, has become much more popular, although it was brought to market as a cancer drug, and its off-label use, its success rates, particularly with women with PCOS, were seen to be much better. In regards to, if you look at live birth rate, 27.5% versus Clomid. So now I think in a race, letrozole's winning, especially for PCOS. Next slide. There was a question of this interesting work that was published about a year ago in the spring, control trial of combination of letrozole and Clomid versus letrozole alone in PCOS. And next slide. I know some of the insurances actually have been wondering what in the world are these people doing? They're using 2 drugs at the same time that should really be used separately. And they were stratified by age and checked to see if they ovulated. And letrozole was 43%, but when you combine them together, you got a double fisted and you got a bang for your buck with a 77%, higher rate, but not significant for clinical pregnancy or live birth. But it is interesting, since they do function in different ways, how they might be helpful. Next slide. There are other things like surgery, and especially way back when, the way that people were diagnosed with PCOS was an anatomical condition that was diagnosed at surgery, when someone would have large ovaries, and here in Chicago was where that was diagnosed. And understanding that a lot of the stroma, if damaged with laser, almost make it look like a golf ball and zap it, could improve the hormonal milieu of PCOS and help them ovulate. Some women do still do this, or wedge resection. However, with that, you might develop adhesions over the area that was cauterized, as well as be too aggressive and end up burning out so much of the ovary that the woman might be in premature ovarian failure, or at least dysfunction. So that one certainly isn't the most popular place to go for PCOS treatment. I think now a new paradigm for treating women who have fertility issues, particularly women with PCOS who are at risk for multiple birth. And really the last person who needs a multiple birth is a woman with PCOS, as they are already at risk for issues such as type 2 diabetes, but bringing that into the pregnancy state of gestational diabetes and all of its concerns. So IVF is now really, I think, is not considered a last resort anymore. And you can actually minimize the risk of ovarian hyperstimulation with a low dose protocol and an agonist trigger, and end up really, helping a couple have a very high success rate, put one embryo in, and it really limits the higher order birth rate, which can happen with ovulation induction, particularly with those stubborn PCOS patients. So I think it's really brought forward. There's increased risk of miscarriage for some patients who have PCOS as well, and whether that's related to the hormonal environment in which that baby's growing, as well as concerns about the hormone affecting aneuploidy. And so PGT has also been brought into the picture of IVF with PCOS. Next slide. So I think in conclusion, if there's anything that's on that text, please go ahead and bring it forward. But I think what we found is we had a fantastic presentation with Dr. Violet Klenov about how to diagnose PCOS, which really is using one of 3 criteria, and Dr. Cooper, who's really gone over how important some of the other health problems can be in lifestyle modification. Medications, even like metformin by itself, still has almost a 10% pregnancy rate, although not as good as ovulation induction by itself. But remember, for your patients to look at the whole person when they're trying to get pregnant. We want to look for diabetes, and while they're in treatment, minimize the risk that the patient would get sick from some of the medicines we might use, and really a low dose or a kind of a minimalistic approach, if you will, to try to get 1 or 2 follicles to grow. But if that's not working, we move quickly to IVF. And if you can go one more slide, at our approach, we think that our Center of Excellence for PCOS has been a wonderful place to bring patients to help them optimize their good prognosis for pregnancy, because sometimes what is our weakness is our strength. And with PCOS, although they have this hormone imbalance, their prognosis really remains quite good. And really our number one goal is healthy mom and healthy baby. So we like to think about reducing all of the risks, but take advantage of some of the positives. And at Vios, we also have some specific vitamins that we've found that are really high quality from a company in Canada, where the patient can order directly from our website, because we really think nutrition and micronutrients are so critically important to women trying to achieve pregnancy, or at least ingredients where they can order them online and know what to get. So with that, we'll take any questions that you guys might have. And while we're looking at that, can I ask Violet and Amber, do you often use the vitamins or metformin for the patients that are trying to get pregnant?
I will answer first too. I absolutely do. I feel as though I like I said, I very much encourage dietary changes and some exercise, but I absolutely encourage the vitamins, because I think as much as we try to encourage getting at least B and C vitamins, I didn't go much into vitamin D, which I think has a fabulous anti-inflammatory role and can really help all patients. Mm-hmm. So I do think as much as we try, patients, even in the diet, don't get enough. So yeah. I do believe in vitamins. Metformin, particularly for me, if their hemoglobin A1C is in the, insulin resistance or pre-diabetes range, there's data to suggest it may slow their progression to diabetes too, above and beyond maybe beneficial things that we talked about. So I particularly with issues with obesity, comorbidities, insulin resistant range, hemoglobin A1C. There's a lot of data that you should do a 2-hour glucose tolerance test in these patients. It's a little more sensitive of a test for PCOS. A lot of my patients don't want to go do a 2-hour, so I at least try to get an A1C when I get their labs if they don't want to do a 2-hour test. But I do use it a fair amount.
Wonderful. We do have one question.
Yeah.
How many cycles with letrozole will you do before going to IVF? Dr. Beltsos, did you want to answer this, or Dr. Klenov?
Yeah.
So typically, you know, data would suggest that if we're going to get pregnant with a letrozole cycle, usually you will become pregnant within the first 3 to 4 cycles if those cycles will be effective. There's no hard and fast rule. It's just that kind of you start gaining in success if you do cycles beyond that. Now, it's a different conversation. We have these, you know, it's an individualized recommendation. If I'm talking to somebody in their 20s and for various reasons IVF may be off the table, then, you know, you can continue those treatments. But generally, after 3 to 4 cycles of letrozole, we're talking about moving on to something more aggressive and successful like IVF as the next step.
Okay, thank you for that. Dr. Beltsos, did you have a follow-up?
Yeah, I think that is pretty interesting. And I think we often wonder, but I would agree that 3 to 4 cycles with ovulation and a good response, you want to make sure that the hormone levels are good. And you can track how someone responds by doing some ultrasounds after they take letrozole. And I think another question that Mindy's asking, Amber, you had mentioned, you know, when to start doing the evaluation and initial PCOS labs after stopping a birth control pill. How do you think that should work?
You know, personally, I think you can check a lot of PCOS labs anytime, you know, and there's a lot of things like your hemoglobin A1C and your vitamin D levels that you can improve whether they're on or off birth control pills. If you check them on birth control pills or just after they've come off in the couple weeks, just know that their testosterone may be a little bit lower because you were treating that while they're on OCPs. So if they just came off, I think you just have to understand that if you're looking for you know, diagnostic criteria, if you will. But, you know, really when we check testosterone levels, if patients are clinically hirsute, they probably have elevated androgen levels. And I think you have to remember that even the testosterone assays are sort of made for men, right? Assays are made to work in their best range. And we kind of look at testosterone levels in women and we use them, but the assays aren't always the greatest. So, you know, I think if you're doing a workup, you can do a workup at any time.
That's awesome. Yeah. And people wonder about, you know, sometimes for fertility, we talk about day 3 labs. Even our nurses can get confused when we're waiting for, you know, to do some of the egg reserve testing on the 3rd day of your cycle, except if you're PCOS and you don't get a cycle, you can do, as Dr. Cooper said, just do them randomly and just say, come on in, you don't get cycles, so let's just see where your body's at. You might catch them in an ovulatory cycle. And post-ovulation, ideally, some of these numbers are good if they haven't ovulated yet.
Angie, I might add just, I think to watch down the pipeline for the providers out there, you know, AMH, which we REIs use all the time. We encourage to look at the ovarian reserve. You might hear us talk about it a lot in women with low egg pools and are worried for diminished ovarian reserve, but you probably will see over the upcoming years, based on a few more trials, AMH actually may be more helpful in these PCOS patients. You know, reproductive age woman in her 20s or early 30s might have an AMH in the 2s or 3s. Women, when you start to see AMHs 4, 5, 6, 7, probably do have some mild PCOS and maybe some subtle ovulatory dysfunction. You start getting a little higher and you get women in the double digits. They probably don't ovulate at all. And I find women, the higher the AMH is, the less likely they are to respond to lower doses of oral medicine. So I encourage really peeking in on that AMH. And sometimes you can understand how stubborn the ovaries are, if you will, all those little follicles there.
Yeah, interesting. Yeah, one study had shown that women with PCOS, 97% of them had a high AMH. So yeah, you're right. I think we'll start to see new diagnostic criteria develop as more data comes up. So, that is a fascinating review, I think. Some stuff to come at maybe a future webinar, Are Children Born of PCOS Women, and what their life looks like if you're a daughter or a son of women with PCOS, and what risks get imprinted, potentially changed through their DNA even, and some fascinating work being done in South America on this topic, but a lot more to learn. So Dr. Klenov, any closing remarks from you?
Yeah, I guess just that we're all here to help these patients, especially with the stubborn ovaries. It can be challenging to get them to wake up and gosh, I've done a week of letrozole, there's no response. What do I do? Can I just, stair step? And you can often just start at a higher dose. You don't need to delay, make them have a bleed. So we're always available to help field those questions. It can be tricky. It can be frustrating. Patients can find these things challenging when their bodies continue not to do what is quote unquote normal. So we are here.
Thank you, Dr. Klenov. Dr. Cooper?
I still stress this is me and my passion in the environment, right? I think we are seeing more inflammation, more obesity, maybe more autoimmune diseases, and in turn, we may see more PCOS. It's hard to say with more industrialization and all this stuff in the environment. So I'm passionate about environmental research, and so I talk a lot to patients about really just teaching them about foods. You'd be amazed how many women with PCOS don't understand, the basics about some foods and preservatives and artificial sweeteners, and just getting their vitamin D up, getting more B and C vitamins in their diet, and more clean eating, and how much just understanding those things can make a tremendous difference in their weight, in their overall health, in their pregnancy outcomes, and even getting pregnant.
Yeah, awesome. Yeah, always an inspiration on that topic, Dr. Cooper, about reminding us environmental toxins. So our DJ,
Thank you, Dr. Beltsos. Dr. Beltsos, do you have any closing thoughts as well?
Thank you. Well, we just appreciate everyone taking time out of your busy day to join us. And we love being able to meet some of our providers from around the country, and being able to proudly show off our team. And at Vios, we're just very blessed to have amazing people, including Michelle and Aaron, who've helped organize it, and Jackie, who's been a lovely moderator of our discussion on PCOS. So we hope you have a lovely evening, and we look forward to speaking to you real soon.
Thank you. Thank you, Dr. Beltsos. Thank you, Dr. Cooper, and thank you, Dr. Klenov. Just still one last announcement. We do have we have another provider webinar on August 24th. You can check our website for details, www.viosfertility.com. Okay, thank you, everybody. I hope you have a wonderful night.
Thank you all.
Guys.